I want to welcome everyone to this WooU University course entitled What's New in the Diagnosis and Management of Glaucoma by Danica Morelli. Next slide, please.
Oops.
And I'm your host, Dr. Carolyn Major, an associate professor at the Oklahoma College of Optometry. And I want to give a special shout out and thank you to Visionary Medical Education for helping host this event. And thank you to the following companies who provided an unrestricted educational grant for this event: Alcon, Glaukos, Reichert, Thea Pharma, and Topcon Healthcare. So if you would, please take a moment and take the pre-test if you haven't done so already. We're going to put a link to that in the chat box there if you need to access that still. And so as a reminder, for each hour of CE units, attendees must be online for a minimum of 30 minutes. And for a COPE certificate, please make sure at the conclusion of the webinar, you fill out the survey link that's in the chat box. The survey will also automatically pop up and appear once the webinar ends. CE certificates are going to be delivered by email and sent to ARBO with OE tracker numbers if you provided us with that. We'll also display a QR code at the very end of the event, but you have to have the OE tracker app on your phone in order to use that QR code app in order to snap that and get credit. CE credits are going to be emailed within 4 weeks, and please ask questions throughout the course, and you can do so by using either the chat or the Q&A box located down at the bottom of your Zoom box. Next slide, please. If you're joining us on your phone, you can also ask questions using the Q&A box up at the top, or you can access the chat box down at the bottom of your screen. And so it's my absolute pleasure to welcome here this evening Danica Morelli, who received her Doctor of Optometry degree from the University of Houston College of Optometry. She then went on and completed a residency at the Baltimore VA Medical Center. She's a clinical professor at the University of Houston College of Optometry, where she serves as Assistant Dean for Clinical Education and Director of the Medical Eye Service. She's a diplomate in the Glaucoma section of the American Academy of Optometry and is the Vice President of the Optometric Glaucoma Society. And Dr. Morelli, go ahead, take it away.
Thank you, Dr. Major. Welcome, everybody. It's a pleasure to be here. I've been reading about WooU for a long time, so when I got the email that said that I was going to get an opportunity to speak for WooU, I was really excited. These are my financial disclosures. I think it's always important to disclose those things to an audience. Nothing that I say is intended to be a commercial for any of the companies that I've consulted for. And all of the financial relationships have been mitigated through COPE. So I'm going to talk about a little bit of this and a little bit of that in the diagnosis and management of glaucoma. Here's our agenda. So we'll talk a little bit about some diagnostic tools. We'll then move on and talk about some of our newer treatment options, finish with a really, I think, exciting look at SLT. So just to kind of go back to the very basics, I think we've really reframed the way that we think about glaucoma. 10 years ago, 15 years ago, I would have said glaucoma is a chronic progressive optic neuropathy. And I think we've just shifted a little bit to say that it is a chronic progressive disease of retinal ganglion cells that results in characteristic optic nerve changes and visual field loss. We know that the damage to the ganglion cell axons occurs at the level of the lamina cribrosa, and that there's selective damage to the superior and inferior poles of the optic nerve. And this is really important in understanding that there's an asymmetry in glaucoma, both between the right and left eye, but in particular within an eye, asymmetry between the top and the bottom. And that's what gives us our characteristic visual field defects. So I feel like this is kind of like my public service announcement. Whenever I'm talking about what's new, what's on the forefront, maybe even what's coming down the pipeline, I always think it's important to remember that the most important thing that we have going for us in asking whether a patient has glaucoma or not is our clinical exam of the optic nerve. So we have lots of interesting tools. We have lots of valuable tools, but nothing beats your examination of the optic nerve. And in general, the big question of, is this glaucoma, needs to start with a look at the optic nerve. If there are characteristic optic nerve changes, then the answer is generally yes. And if there aren't those characteristic glaucomatous optic nerve changes, the answer is usually no. But of course, our OCT may help us make that diagnosis a little bit earlier. So I'm a big proponent of saying every time I speak about glaucoma diagnostics that we want to let our instrumentation and our technology support our own clinical exam. And I think a big challenge is the tendency for us to kind of relegate our clinical exam of the optic nerve to an afterthought. So we just want to make sure that we're looking for the 5 big changes that we would see in glaucoma. So one is a large CD ratio relative to the size of the optic nerve. So it's always important to think about whether you're looking at a small nerve, an average size nerve, or a large nerve, and put that CD ratio into context. Of course, we want to look at the rim and look for focal or diffuse thinning. That's where our isn't rule or our IST rule, whichever one you use, comes into play. Look for focal or diffuse retinal nerve fiber layer loss, and we can see that on our clinical exam. We can also see that in photography with red-free filter, and of course we use our OCT to quantify any changes in the nerve fiber layer. Peripapillary atrophy is one of those things that I sometimes feel the least confident about, because there can be so many different things that can go on in the peripapillary region. You can have crescents and different types of atrophy, but specifically we want to be looking for beta zone peripapillary atrophy. And then optic disc hemorrhage is a really important one that I think we need to be intentional about looking for. Studies have shown that optometrists and ophthalmologists are not very good at picking up optic nerve hemorrhages on clinical exam. I pride myself on always being very intentional, saying, look for that disc hemorrhage, look for it, look for it. But just 2 weeks ago, I had a patient. I've been following her for a long time. I examined her optic nerve, didn't see a disc hemorrhage. We got fundus photos that day, and sure enough, there was a disc hemorrhage. So a disc hemorrhage is something that we need to always be looking for. So that's kind of I'll step down from my soapbox, but just to remind you to always really do a careful clinical exam of the optic nerve. When we look at the retinal nerve fiber layer, it can help us to differentiate those patients who have pathological changes from patients who have just physiologic cupping. And we know we've known for 30 years that nerve fiber layer loss, visible nerve fiber layer loss, can precede glaucomatous visual field loss by several years. And you can look for nerve fiber layer loss on your clinical exam. You can look for it on photography, but we've all become very used to using spectral domain OCT to look in a qualitative sense, maybe when we're looking at a thickness map, but also to quantify the thickness of the nerve fiber layer. And so these are just 3 different types of OCTs. And I think for the most part, everyone who's diagnosing and managing glaucoma is using OCT for the peripapillary retinal nerve fiber layer. But one of the things that I've been surprised about in the last few years when I go around to different regional meetings and speak is that not a lot of optometrists are using the macular scans in the diagnosis of glaucoma. And we've known about this for a long time, and we've been really utilizing macular scans in the diagnosis of glaucoma for about 10 years. So you can look back historically, and about 25 years ago, there was a research scientist who had a big non-commercial scanning laser ophthalmoscope in his lab, and he was able to demonstrate thinning of the macula using the scanning laser ophthalmoscope in patients with glaucoma. At the time, that was interesting, but it didn't really mean anything to us clinically because we didn't have an instrument that could help us out there. If you fast forward about 5 years later, David Greenfield reported a correlation between the macular thickness. So just using a standard macular cube scan, he could correlate macular thickness with the mean deviation and even the pattern deviation on a Humphrey visual field. So that was a little closer to being clinically useful. But really, a lot of what we know, perhaps most of what we know about the macula in glaucoma comes from the work of Don Hood up at Columbia University. He and his whole lab, he has a very large lab group, has done an extensive investigation of the ganglion cell interplexiform layer in early glaucoma, and they've coined the term macular vulnerability zone for the area of the macula that's most commonly damaged in early glaucoma. So this is an image out of one of his seminal papers really on the macula in macular damage in glaucoma. If you were to sort of summarize his lab's work using these two images, the first thing that they did was they tried to see if they could accurately predict where individual retinal ganglion cells would insert their axons on the optic nerve. And they did this both in non-human primates and in human cadaver eyes. And what they found was that they could predict with a really high accuracy where individual ganglion cell locations would send their axons to insert in the optic nerve. So that was sort of step one. Then they said, all right, well, we know that the most common area of damage in the optic nerve is that infratemporal sector of the optic nerve. So 7 o'clock in the right eye, 5 o'clock in the left eye. So if this is the area where the damage is most common, where do those ganglion cell bodies live? And it turns out that they live inferior and temporal to the fovea. And so that's the area that they've termed the macular vulnerability zone. It's the area that's most commonly damaged in early glaucoma. So every single commercially available OCT has a glaucoma-specific macular protocol. This is an old article that talked about some differences between the OptiView, the Spectralis, and the Cirrus. The details of that aren't super important, but just to recognize that they all do it a little bit differently. For example, the Spectralis uses the full macular thickness. The Cirrus OCT by Zeiss uses the ganglion cell interplexiform layer segmentation. An instrument can't really separate out the ganglion cell from the interplexiform layer, so it's sort of like a combo layer. And then the OptiView uses the ganglion cell interplexiform layer as well as the nerve fiber layer. So they all do things a little bit differently, but the printouts are actually fairly similar. This is an example of an OptiView, and I don't know that this is what the printout looks like now. I don't have access to this instrument, but just to kind of show you what we're looking for. Remember, we don't have any ganglion cells at the fovea. They're all sort of squished out to the side. But what we're looking for here is a very uniform annulus of inner macular thickness surrounding the fovea. When we're missing that, we'll get some indication that there's a deviation, and then we'll get information about the significance. Now, in this particular example, where the ganglion cell interplexiform nerve fiber layer is thin is superior. And one of the things that's really important in this type of scan is to look at how well it respects that temporal raphe. So even though this kind of looks like an optic disc, remember, this is the fovea here. This yellow dot is the fovea. And so this is the temporal raphe. And this damage in the macula is really is localized to one side or the other. Most of the time inferior, but in this example, superior to that temporal raphe. This is the Cirrus OCT. This is one of my patients. Again, we don't have ganglion cells in our fovea. We expect to see a pretty uniform annulus of these kind of yellows and red colors. And in glaucoma, what we will see is this sharp distinction on the temporal side of the fovea. And some people have called this a squeegee sign. It looks like you sort of put a squeegee up there and swipe down. I've heard it called the nautilus sign because it kind of looks like a nautilus seashell. But what we're seeing is this acute asymmetry, or this very distinct asymmetry between the thickness of the GC-IPL superiorly versus inferiorly. We can see it in our thickness map. We can also see it in our deviation map. And very similar to that OptiView that I showed you, you could just take a Sharpie marker and just draw straight across that temporal raphe. Now, the Spectralis instrument does something a little different. This is not my slide. This is from the company. But they use the full thickness of the macula, and they base their entire glaucoma macular protocol on symmetry. So the idea that we're pretty symmetric individuals, and we would expect that we would have this uniform thickness of the macula surrounding the fovea. So this instrument creates an 8x8 grid centered on the fovea and does a really beautiful symmetry analysis. It does a symmetry analysis of superior versus inferior within each eye, and then it does a right-left symmetry analysis as well. So this is what it looks like. This is a superior-inferior symmetry analysis for the right eye and then for the left eye. The actual printout looks sort of like this. So we have our right-left, our right superior inferior symmetry, and then we have our right left asymmetry. This is a really beautiful way to capitalize on that really distinct feature of glaucoma, which is superior inferior asymmetry. This is Dr. Michael Shaglazian sent me this image because they didn't have an image of the TopCon instrument. They put their optic nerve, the peripapillary retinal nerve fiber layer, and macular scan on the same printout. And you can see very clearly this patient has an inferior nerve fiber layer defect that we can see on the nerve fiber layer printout. But we also see that they have that inferior intermacular thinning as well. So I can tell you that when we first began to look or hear about looking at the macula in glaucoma, I really questioned, did I need more information? I was sort of like, I felt like I was already on information overload. Did I really want one more piece of data that I had to consider? I've got packs and pressures and nerve fiber layer and fields and corneal hysteresis and all these different things. Did I really want to start looking for damage somewhere else? But you know, if you think about reframing glaucoma as a disease of retinal ganglion cells, it really makes sense to look in the macula because about 50% of the entire retina's ganglion cells live in the macula. So if you want to study a disease of the macula, of ganglion cells, go where they live, and that's right in the macula. Also, the macula is more reproducible, and there's less variability, less anatomic variation in the macula compared to the peripapillary region. So I always think about think about the last 10 non-diseased macula that you looked at, that you examined. They all look the same, right? But now think about the last 10 non-glaucomatous optic nerves that you looked at. They all look different. Some are tall and skinny, some are short and fat, some are tilted, obliquely inserted, large, small, blood vessels coming out at different places. So there's a lot of anatomic variation in the peripapillary region that we just don't have in the macula. And there's better superior-inferior symmetry and better right-left symmetry in the macula, in normal macula, compared to the peripapillary nerve fiber layer. So those are good reasons that we ought to be looking at the macula for diagnostic testing. But there is no such thing as a perfect test. And so when you have concurrent macular disease, looking at the GCIPL or looking at the full thickness of the macula is not going to be helpful when you're trying to use that as a glaucoma tool. I would say that's particularly true for intermacular disease, so vitreoretinal interface disorders, VMT, VMA, epiretinal membranes, but even more advanced outer retinal disease, outer macular disease, like a macular degeneration. If you have geographic atrophy and you have sort of subsidence of those inner retinal layers down because the RPE is dropped out, the instrument's not going to be able to segment out the layer that it wants to. So when you have concurrent macular disease, your ganglion cell maps are not going to be helpful. These are just a couple of patients that have segmentation errors. Whenever you have these kind of dark blue triangles like we see here and here, or if you have these kind of bright red blobs like we see over here and over here, that's just an indication to you that this is not well segmented. This is probably not going to be a patient that you're going to be able to get useful information with the macular glaucoma protocol scan. So let's talk about a case. This is Leo. He's a 71-year-old African-American man who got referred to me for a glaucoma evaluation, really mostly because of his age, his race, and kind of borderline high intraocular pressure. His ocular history was unremarkable. Like many 70-year-olds, he had type 2 diabetes and hypertension, both of which were well controlled. There was no glaucoma in his family that he was aware of. His vision was good, his slit lamp was normal with the exception of some early cataract changes. His intraocular pressure was 23 on the day that I saw him, and that was mitigated to a certain extent by pretty thick central corneas. So nothing that was really screaming glaucoma here. And this is his RNFL OCT. And I think it's kind of like looking at, at a train wreck. You kind of can't help but look over here in this left eye at this inferior temporal area that's showing some yellow and red, indicating that he's thinner than the reference database here. And this is exactly where we would expect glaucoma damage to occur. But his visual fields are normal. Now this is his right visual field. This is his first visual field. It did clean up when we repeated this, but in neither eye do we have any glaucomatous pattern loss on his visual field. And what did I say at the very beginning? Let's go back and let's look at the optic nerve. And I would argue with anyone, but these are not glaucomatous optic nerves. Remember, the nerve fiber layer OCT was showing potential thinning in this area right here. But if you look at the rim of this optic nerve, it's beautiful. It's really thick. It really isn't worrisome at all for glaucoma. So what's going on there? In this example, we have a nasal deflection of our blood vessels. When the instrument separates out the nerve fiber layer, it's not just ganglion cell axons, it's ganglion cell axons, some glial tissue, and blood vessels. And the blood vessels actually make up a large part of the thickness of the RNFL. And so the instrument is expecting blood vessels to kind of come out at the 5 o'clock and 1 o'clock locations on a left eye. But in this example, these blood vessels are really shifted over nasally. If we come over and we look at our peak inferior nerve fiber layer, it's actually very, very thick in both eyes. It's just shifted nasally. So this patient has an axis shift, which is explainable because of an anatomic variation of where his blood vessels exit. So the next test that I'm going to do is going to be a macular scan. And if this is glaucoma, we really expect to see that very distinct cut along the temporal raphe, and we don't have that at all. I'm confident that Leo does not have glaucoma, even though at first glance, his RNFL OCT looks a little suspicious. But here's a different case. Tony was a 51-year-old hypertensive Hispanic male who got referred to me for a glaucoma evaluation because of the appearance of his optic nerves. Now, his ocular history is significant. He had LASIK about 20 years ago, and he had PRK enhancement just in the left eye about 15 years after that. So he's had multiple corneal procedures on that left eye. Now, his grandmother had glaucoma before she passed away, and I was able to discern from him that she took drops, she had laser, and she did lose some vision from her glaucoma. So I was pretty confident that that was a real family history. His uncorrected acuity was 20/20 in each eye. He's so happy with his refractive surgery. His pupils, motility, confrontation fields were all normal. His slit lamp exam was normal, except that you could still see his LASIK flaps, and his angles on gonioscopy were open to ciliary body, 360 degrees. The highest pressure that I ever measured on Tony, and I saw him multiple times, was 17. But look at these corneal thicknesses, especially in that left eye that had 2 refractive procedures. We're definitely underestimating with Goldman tonometry what that true intraocular pressure is. So when we take a look at Tony's optic nerves, when I look at these, I just sort of go, oh no, what am I gonna say about these optic nerves, right? Even though he sees 20/20 without any correction, he has myopic eyeballs. And when you look at these optic nerves, it's very difficult to decide, are these glaucomatous or are they simply myopic optic nerves? Now, you don't have the benefit of having a stereo view, but I did. And when I looked, I was particularly concerned with the infratemporal rim in the left eye. Certainly he's thin in the right eye as well, but this was the area that I was most concerned about. We went ahead and got an RNFL OCT, and very characteristic of high myopes, he had just kind of not very thick nerve fiber layer, but nothing that was really screaming glaucoma. There wasn't an obvious wedge defect or anything like that. It was sort of like a, I'm not sure what to do with this RNFL. So we had just started utilizing macular scans, and this was his ganglion cell interplexiform layer scan. In the right eye, we have ganglion cell interplexiform annulus surrounding our fovea, and this is actually a pattern that's very characteristic of high myopes, axial myopes. But in the left eye, he has this squeegee sign, or a better term is probably the temporal raphe sign, where he has this dramatic asymmetry, pretty normal thickness of the superior ganglion cell layer, and just almost nothing inferiorly. We can also see it on our deviation map, again, that very sharp temporal raphe line. So I have no doubt that this is glaucoma. Now, when we look at Tony's visual fields, see if I can get this to move, I thought they looked pretty normal. I was willing to say that these first-time visual fields were essentially normal. But this brings up another point, talking about the macular scans in glaucoma, it brings up another point, and that is utilizing the 10-2 visual field in early glaucoma. So again, 10, 15 years ago, if you had asked me if I ever run 10-2s in glaucoma, my response would have been, yeah, when the 24-2 is pretty much gone and they only have a little central island of vision left. But we know now, especially from Don Hood's work, that there can be early damage in the macula, and that may not show up well on a 24-2. So 24-2 or 30-2, those points are 6 degrees apart, and they really don't sample well in the densest area of ganglion cells. But a 10-2 test will test in the central 10 degrees, and those test points are 2 degrees apart. So we're sort of zooming in on that very sensitive macular area if we use a 10-2. So again, from work from Don Hood, I want to show you this image. So on the left-hand side, we obviously have a fundus image with an OCT of the ganglion cell interplexiform layer superimposed on it. And then all of these black dots are points on a 24-2 visual field and where they would be sampling in the retina. So when we look at that most dense area of ganglion cells, we really only have 4 points in that entire visual field that will test in that area. If we look over to the right, what we have are those same points on the 24-2. Those are represented by the larger gray dots. The white square represents the region of this macular scan here. And then all these little tiny dots, the little tiny gray dots, are all the test points on a 10-2 visual field. So if we have patients who have damage in this macular area, a 10-2 is going to sample that area much better. So if we go back to Tony, I said I thought his visual fields were normal. But once I saw that infratemporal ganglion cell loss in his left eye, I went back to this visual field and I wondered if this was just a rogue point or if it was really representing damage to the infratemporal part of his macula. So I went ahead and did a 10-2 on him, and suddenly that 1 point on a 24-2 becomes a pretty sizable area of loss on the 10-2 that correlates very, very well with the damage to his macula. Now, the question always comes up, am I running 10-2s on all my glaucoma suspects and glaucoma patients? And my answer is 100% no, I don't. Patients don't like visual fields, doctors don't like visual fields, technicians don't like visual fields, but this is how I sort of handle that right now. I run a 24-2 as my standard glaucoma suspect or glaucoma test. If that 24-2 has a visual field defect that's characteristic of glaucoma, I'm not really going to move into the 10-2. But let's say that 24-2 is clean and I have damage on the macula, on my macular OCTs, then I'm going to get the 10-2 to just see if maybe it's going to pick up something that the 24-2 missed. The take-home message for looking at the macula in glaucoma is that damage to the macula in early glaucoma is common, It's not visible on clinical exam. We can see thinning of the neuroretinal rim. We can see neurofiber layer loss, but I can't use my 78 diopter lens and recognize that there's ganglion cell thinning in the temporal part of the macula. I just can't see that. So in order to detect that damage to the macula, we have to image it. Also remember that the 24-2 may undersample that area, and so we may need to alter what visual field we're doing. There is a new visual field on the HFA3, the Humphrey Field Analyzer. It's a standard 24-2 with 10 additional points represented in yellow here on this image. 5 above the horizontal midline and 5 below the horizontal midline in that central 10 degrees. You can kind of think about this like a hybrid of a 24-2 and a 10-2. It sort of bothers me, the test points that they chose. They seem so random, but they weren't picked at random at all. They were picked as the most commonly missed points in patients with glaucoma who had this early macular damage. So when you print it out, it looks like this. The grayscale really looks just like a 24-2, but we see the central points added in our raw data and in our deviation map. So this is another way that you can test a little better in the central visual field. So I want to talk a little bit about headset perimetry or virtual reality perimetry. And I think the biggest question right now is this ready for prime time? So I totally understand the appeal of this, right? It's small. You don't have to have a separate room where you put a big bowl perimeter. So if space is an issue, this is a really appealing option, right? I can think of patients that I have with glaucoma who are in wheelchairs or who maybe have some back or neck problems that make it very difficult for them to sit at the bowl perimeter, at the perimeter. They could put one of these things on and do their perimetry right in their wheelchair or in your exam chair or in the waiting room or in the pre-test room. So there's a lot of appeal to these instruments. In addition, they cost less than a typical bowl perimeter. So the reason I say, are we ready for prime time, is that there are a couple of problems with these instruments. I've consulted with 2 different companies, and I'm not going to name those companies, but one of them I'm pretty excited about. But one of the things that you can't get past on all of these headset perimeters is that they're battery powered, and you can't get a light that's brighter than 15 dBs on a Humphrey Field unit. And that means that for patients who have threshold values below 15 dBs, you're not going to be able to test those points using this headset perimetry. Now, some of the companies have tried to get around that by altering the background luminance, but when you do that, you're not really testing the same thing. So where I think these may be really valuable is for screening tests and for patients who have early glaucoma who don't have really depressed points. Now, if that patient then progresses to a point where their threshold value would be less than 15 on a Humphrey Field, I don't really think you're going to be able to utilize these. So I think they're great. They'd be great for screening settings. I can imagine that they would be great if you have, a nursing home practice, or you go to you do maybe hospital-based optometry and you need something portable. I also think they could be very valuable in early glaucoma, like I said, pre-parametric or early parametric glaucoma, but they're not going to really be able to be utilized in moderate to severe glaucoma. The other challenge, and this is not specific to headset perimetry, it's really a challenge for all new technology, is that once you have patients that you have years and years of data on a particular instrument, switching over to a new instrument is really tricky because you lose the ability to follow that patient over time. So if I had one of these, and I'm actually getting one, I think, very soon, if I had one of these in my practice and I wanted to start using it on patients that I already had years of data on, I would make sure that I run several visual fields in a relatively short period of time to make sure that that visual field is stable before I switch them over to this. I'm excited about this. I think there's some technical challenges that still need to be worked out here. So let's move on to the management of glaucoma. And I just want to briefly talk about medications. So, we can lower intraocular pressure by either decreasing the amount of aqueous that's produced, increasing outflow either through the trabecular meshwork or through the uveoscleral pathway, or by decreasing episcleral venous pressure. I want you to just think for a minute about the way that we've been lowering intraocular pressure for the last 26, 27 years. We've been mostly using prostaglandins, which work on the uveoscleral pathway, or aqueous suppression, so our beta blockers, brimonidine, and carbonic anhydrase inhibitors. And we've really been ignoring the trabecular meshwork. So I'm old enough that I used to prescribe pilocarpine for primary open-angle glaucoma. But once prostaglandins came out, we really threw away pilocarpine. And for good reasons. It was 4 times a day, and there were lots of side effects. But that meant that we were really not addressing the major outflow barrier in glaucoma. So people don't have high intraocular pressure because they're producing too much aqueous. They have high intraocular pressure because there's some kind of dysfunction in the trabecular meshwork. And so it makes sense to me that we want to try to decrease that resistance to outflow in the trabecular meshwork. And we have 2 classes of medications now that will do that. So neither of these is brand new. They've both been on the market for about 4, almost 5 years, I think. The rho kinase inhibitors, the drug that we have is natarsadil. This inhibits rho kinase and norepinephrine transporter, and its main mechanism of action is to increase trabecular outflow. It sort of relaxes the spaces in the trabecular meshwork and allows for easier aqueous outflow through the TM. It also decreases episcleral venous pressure by causing vasodilation of the sort of more distal outflow channels in the eye. And that's the only drug that we have that we know lowers episcleral venous pressure. Ropressa has been shown to be efficacious and safe in clinical trials. And one of the downsides to Ropressa or natarsadil is the hyperemia that goes along with it. And so in the clinical trials, about 50% of patients experienced hyperemia. My clinical impression is that it's more than 50%, but that's what the data would show. And in the trials, most of the cases were mild hyperemia. I have patients who have mild hyperemia. I also have patients who have really significant hyperemia. I usually tell them to expect the eye to be very red and to give it a couple of weeks, because sometimes that redness will settle down a little bit after the first 2 weeks. Another interesting side effect of natarsadil is little conjunctival hemorrhages. These tend to be very tiny, kind of petechial hemorrhages located at the limbus. There's no reason to discontinue the medication because of those, but the patient may notice them and may be bothered by them. And then a unique side effect that we don't have with any of our other glaucoma medications is the development of corneal verticillata. That happens in about 15 to 20% of patients using natarsadil. Now, this image on the left is actually an amiodarone verticillata. It's very big, it covers most of the cornea, and my clinical impression with natarsadil is that it's much smaller, so you may be able to see these just kind of little whirly golden colored deposits. They're at the base of the epithelium. They don't cause vision loss. There's no need to discontinue the medication when you see this, but you should just be aware of it because it's a little bit startling when you see it. This is a real-world efficacy trial, so this isn't one of the pivotal trials, but I think it's really an interesting study. This was done in practices. It was natarsadil could be added or substituted for any of the patient's existing glaucoma medications. I want to introduce how this graph is designed, and then I'll tell you what the 4 different graphs represent. So on the y-axis, we have the percent of patients from 0 to 90% who were meeting on the x-axis predetermined endpoints, IOP of 18 or less, 17 or less, 16, 15, and 14. Now, this first graph over here is all of the patients who were enrolled in this study where natarsadil was added. And you can see that there were a much higher percentage of patients reaching all of those predetermined endpoints. Over here on B, the upper right graph, is natarsadil added to a prostaglandin. So we can see, let's say 27% of prostaglandin users were reaching a target pressure of 18 and 73% once natarsadil was added. kind of more impressive is this graph down on the lower left, which is notarsadil added to more than one medication. It could be added to a prostaglandin plus one medication, a prostaglandin plus a combo. It could even be added to 4 medications. And we still see that there's a much higher percentage reaching all of those predetermined endpoints. And then graph D, which isn't quite as dramatic, was actually notarsadil replacing 1 bottle of medication. So it is definitely an effective medication. One of the challenges is overcoming the side effects. Of course, we also have, shortly after Ropressa was introduced, Rocklatan got FDA approved. Rocklatan is notarsadil with latanoprost. It's our only combo medication that has once-a-day dosing, and in the States, it's our only combo med that has a prostaglandin. They have them in Canada and Europe, but this is the only one that we have in the US. Of course, we have the side effect profile of both agents, but I really like this drop. It is, I always tell this story. If you've heard it before, I apologize, but at my house, I cook and my husband does the dishes, and nothing makes him happier than if I cook dinner using one pot, right? There's just one thing to wash. As a glaucoma doctor, nothing makes me happier than my patient being able to have their IOP controlled with 1 drop a day. I mean, that's pretty remarkable. And we have 2 very effective medications in 1 bottle with this combo. The other new class of medications is really just a modification of our latanoprost, and that is the addition of this side chain to our latanoprost acid. Once this drug, latanoprostene bunod, goes through the cornea, esterases cleave off this side chain, and it releases nitric oxide into the anterior chamber. You know, probably you don't think about nitric oxide when you think about glaucoma. You probably think about blood vessels or blood pressure, but nitric oxide is important in IOP regulation, and glaucoma patients have been shown to be deficient in nitric oxide markers in their anterior chamber. So a lot of different companies have been trying to hook nitric oxide onto existing glaucoma medications. This is just the first one that was able to do it. Latanoprostene bunod goes by the trade name of Fyzolta. It results in increase in trabecular outflow, very similar to the Rho kinase inhibitors. It relaxes that trabecular meshwork and allows for easier aqueous outflow through the conventional pathway. Now, I think it's important to remember that the heavy lifting with latanoprostene bunod is really done by the latanoprost. So the major mechanism is still uveoscleral outflow, but we also have this addition of trabecular or conventional outflow. It's been shown to be efficacious, non-inferior to timolol, and doesn't have any additional side effects that we've recognized other than the ones that we've become so familiar with our prostaglandin analogs. I want to move into drug delivery here. This is the bimatoprost SR or Durista little implant that is done at the slit lamp in the office, so you don't have to go to the operating room. This is a preloaded little applicator with a beveled needle. The patient is anesthetized, and then a drop of betadine is put into the eye for sort of disinfecting. And then this needle is inserted into the anterior chamber, about 2 bevel lengths, and then the activator causes this little pellet, which is laden with bimatoprost, to just go down into the inferior angle. This will ultimately dissolve completely away. It's not made of metal or anything. It's sort of like a dissolvable suture in a way. And it can take about a year for it to completely go away. Now, it is designed to release bimatoprost for about 3 months. And the idea was that after 3 months or whenever the effect began to wane, then another pellet or implant would be inserted. Unfortunately, the FDA only approved single injection of this, and so it has limited usefulness. But one of the things that's been really interesting is to see that even though it's designed to last for 3 months, a lot of patients will have much longer IOP control. This was a 24-month clinical trial of the sustained release, and a single injection actually controlled IOP for up to a year in 40% of the patients, and up to 2 years in 28% of the patients. So even though we say this is probably going to be for about 3 months, we know that in a fair number of patients, it's going to last a lot longer than that. So where does this fit? Because it is not approved for multiple injections. So I think there are some limited areas where this can be very helpful. One of them would be in patients who have ocular surface disease, who are maybe trying to get their surface in a little better shape for cataract surgery, for example. And so you could go on a drop holiday or decrease the number of drops by inserting one of these little implants and allowing a little better ocular surface for that cataract surgery, for example. Or I had a patient who was going to have a hip replaced and knew that they were going to be in kind of a rehab facility for several weeks, and they didn't really want to have to use their glaucoma drops during that time. They just felt like there was going to be a lot going on, and so we sent them for a Durista implant. More recently, we have a different type of implant. This is a slow-releasing travoprost implant called the iDose. This is very different. This is done through a clear corneal incision in the OR. This is a little metal device that has a filter on the end. This is inserted and anchored into the sclera through the trabecular meshwork, and it's designed to release travoprost over a 3-year period of time. This was FDA approved in December and is now currently available. Again, this is going to be done in the operating room, not something as simple as the Durista implant, but much longer duration of action. So the last thing that I want to talk about is SLT. And so this is supposed to be what's new in glaucoma. And you may be thinking, well, like SLT is not new. It's been around for 22 years. And that's true. And in those 22 years, we have lots of studies that show it's efficacious, it's safe. But historically, it's really still been relegated to second-line care after a patient is started on medication, and sometimes in select patients used as first-line care. I really want to talk about 3 different aspects of SLT, though. The first thing I want to talk about is the LIGHT trial. I think everybody's familiar with the 3-year results of the LIGHT trial. This is a study done in the UK, taking newly diagnosed ocular hypertension and open-angle glaucoma patients and randomizing them to either get medical therapy as a first-line treatment or SLT as their first-line treatment. And in this study, the major outcomes were health-related quality of life, clinical efficacy, and cost effectiveness. I'm not going to talk about cost effectiveness because in the UK they have a different type of healthcare system. Initially, these patients were followed for 36 months, and at the end of 36 months, there was no difference in health-related quality of life. I find that really interesting. I think the fix it and forget it kind of idea of SLT seems like it would be really much more favorable, but in the 36-month results, both groups were very happy with their treatment. If you look at the proportion of patients who were reaching target, it was very, very similar. 93% of SLT and 91% of medication first groups were meeting their target pressure. None of the SLT patients had to be escalated to surgery, and 11 patients in the medication first group did. So still, both groups very, very favorable. And the bottom line from the 3-year trial was that SLT provided medicine-free glaucoma control for at least 3 years in about 75% of the subjects receiving SLT. Now, they could have a second SLT within that 3-year period of time, but still, that's pretty impressive results and really gave credence to offering and even recommending SLT as a first-line therapy. What we now have, it's about a year old, we have the 6-year results. And what happened in the 3 years following the initial 3 years was that the medication group could then be offered SLT, and the SLT group could have a third SLT if they needed it. When we look at the 6-year results, there was one quality of life study, specifically the glaucoma symptom scale, which was things like burning, smarting, stinging, tearing, dryness, that sort of thing. That was better in the SLT group, but the other quality of life measures were still very equivalent between the two groups. Efficacy remained very good. In the SLT first group, almost 70% of the subjects remained at or lower than their target pressure without the need for additional therapy. So no drops, no surgery. More eyes in the medication group exhibited progression. although both groups did have progression. And then there was more surgery in the medication group as well. So this clearly tells us that SLT is a really good option for first-line care. The second thing I want to talk about SLT is the COAST trial. This is clarifying the optimal application of SLT therapy. This is really interesting. I only learned about this about a year ago. This is a study in the United States and in the UK that is going to randomize newly diagnosed ocular hypertension in primary open-angle glaucoma patients to either standard SLT, repeated as needed, so kind of do the SLT, if the pressure starts to go up in a year, repeat the SLT, and so on, versus an annual application of low energy SLT. Now, this was actually a way to treat using SLT that was, I think, initially done in a Caribbean country where access to care was very limited. And so they would go in and do this low energy SLT on an annual basis. And that was actually easier for the patients to comply with than using drops or having other types of therapy. Arvo, about 5 years ago, Stefano Gandolfi reported a study looking at SLT versus the old ALT versus low energy SLT as primary treatment in glaucoma. And low energy SLT really was the winner in terms of years to topical treatment and the percent of subjects remaining drop free. The low energy SLT was the winner. So the COAST trial is just a much larger version of looking at which is better, traditional SLT as needed or this low energy SLT. And basically what they do is they lower the power by about 50 to 60%, and they put fewer spots in on the eye, and they do it on an annual basis. There are lots of sites across the United States. If you are interested in seeing if there's a site near you, if you're interested in maybe referring some of your patients to be subjects in the COAST trial, you can go to coasttrial.org, and they have a really nice website, and you can see if there's a site near you. And then the last thing I want to talk about with SLT is the use of direct SLT. This is the Eagle. It's a direct SLT unit made by Belkin. It was FDA approved in the United States in December. It's been available in Europe for a little bit longer. This is a Q-switched frequency double YAG laser, just like the SLT laser, has the same wavelength, but you don't use a gonioscopy lens. You position your patient at the headrest and chin rest, just like you would for an autorefractor, and then you push a button, and simultaneously 120 SLT laser spots are delivered through the peripheral cornea to the trabecular meshwork. It uses an iris tracker to account for any movement of the patient. Now, one thing that's different about this, in addition to not needing a gonioscopy lens, is that the application time is much longer. So, the traditional SLT is 3 nanoseconds, right? This is 1.5 to 2 seconds application time, but all 120 spots are delivered at the same time. So you can see here, this is a little drawing of SLT conventional, which you would direct the laser energy to the mirror, which would then send it to the trabecular meshwork, and the direct SLT just goes straight through the peripheral cornea. There are some preliminary studies. The Glorious trial is one that show very similar results with the Eagle unit compared to traditional SLT. So again, this is FDA approved in the United States. It'll be very interesting to see where we end up with the direct SLT. Now, one thing I'll say, because I know like the no gonio lens is like so appealing to a lot of people, don't throw your gonioscopy lens away, because we still have to know what the gonioscopy looks like when we're making the diagnosis of glaucoma. But I have to say it's pretty appealing to think about just setting them like setting your patient to this instrument like they're at an autorefractor and pushing a button and the SLT is done.